Assalamualaikum and good morning to all our viewers. Welcome to NIH Continuous Medical Education CME Session 2023, organized and brought to you by Sector for Research Information Resources NIH. We are now live from NIH Studio Setia Ala and also via our YouTube channel, NIH Ministry of Health Malaysia. So I am your MC for today. My name is Nurul Syarbani Eliana. I'm a research officer from the Office of NIH Manager, NIH Malaysia. So before we start, let's have a sneak peek to the montage that we have prepared for you.
We understand that healthcare is not just a word, it is a way of life. A health system consists of all organizations, people, and actions whose primary intent is to promote, restore, or maintain health. Like any other system, it is a set of interconnected parts that functions together to be effective. Health systems research provide evidence to health managers and policymakers at all levels. Our aspirations fall into 4 pillars: enhance our capacity and capability in health systems research, strengthen our alliance with local and international partners, promote and advocate translation of knowledge, promote research uptake. IHSR has 6 centers: Center for Health Outcomes Research, Center for Health Equity Research, Center for Healthcare Quality Research, Center for Health Economics Research, Center for Health Policy Research, Center for Health Services Research. We conduct research for evidence-based policy, continual learning, and consultancy to achieve the aspiration of the Ministry of Health, a nation working together for better health. Let's deep dive into the 3 core aspects to understand further. In research, we collaborate with our stakeholders to improve quality and deliver more equitable healthcare services for the attainment of better population health. We conduct research methodology continual learning program to a diverse range of health professionals. We have trained healthcare professionals and support staff in health policy and systems research. We provide consultancy by our subject matter experts, including research methodology and technical advice at local and international level. Let us go deeper into the past and present work, be it locally and globally. We advocate for health system strengthening. Our research area revolves around WHO health system building blocks. Here are some of our research examples. Through our continual learning, we are able to continuously build competency and capacity in research and quality assurance, quality improvement, empowering others to strengthen the health systems. In our core aspect of consultancy, we can see our achievements clearer within our various on-the-ground consultancy services, where we go to different stakeholders and practitioners in the healthcare system. We aspire to continuously build capacity in health policy and systems research, and taking evidence further. A well-functioning health system working in harmony is built on having trained and motivated health workers, well-maintained infrastructure, and a reliable supply of medicines and technologies, backed by adequate funding, strong health plans, and evidence-based policies. We open our doors to any fellow collaborators from all over the region and world to partner with us as we bring the Malaysian healthcare system to the next level. Because health should be something which does not see borders or geographical lines. Health is for everyone.
All right, welcome back. So I just have a quick announcement to make. For those who just joined us, do register yourself at the link provided in the description, or should you have any inquiries, any comments, any feedbacks or any questions, just drop your questions in the link provided, and then I'll read your question towards the end of today's session. So guys, today is the 5th series of NIH CME for this year, which provide a platform for NIH researchers to share their experiences, their knowledge and their research findings to others. So together with us today, sitting next to me is our special guest on board, Dr. Izzatul Rahmi Muhammad Ujang. All right. So, Doctor, how are you today?
Alhamdulillah, thank you.
I heard that you are not feeling so well.
Yesterday, I'm much better today.
You're much better today.
Yes.
Okay, so just bear with me for just about 1 hour and then you can get your rest.
Okay, sure.
All right. So let me give you a brief description about our guest today. Dr. Izzatul Rahmi is a medical officer in the Center for Healthcare Quality Research from Institute for Health System Research, IHSR, NIH. She grabbed her MBBS degree from University of Melbourne in 2010, and she started her journey in IHSR in 2014, where she was positioned in quality division. The past 9 years in IHSR has seen her developing capacity and expertise in the field of quality and quality improvement in healthcare. She involved in various research projects pertaining to quality of healthcare services. She gained experiences in delivering and facilitating training for quality assurance, quality improvement, co-leading the development of training module, and providing consultancy in various shapes and forms related to quality improvement initiatives at facilities, state, and national level. So for today's session, she is the principal investigator for her project entitled Impact of COVID-19 Pandemic on Healthcare Accessibility in Malaysia. So without further ado, I would like to invite our speaker on board to deliver her presentation. But before that, the limelight are yours, Doctor.
Thank you. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh, Cik Eliana. Thank you very much for the kind introduction. Good morning to all of our audiences. Okay, so today I'll be sharing on a topic titled Impact of COVID-19 on our public primary care services utilization in Malaysia. So today's presentation is actually part of a bigger study on healthcare accessibility during the COVID-19 pandemic. But for today's presentation, I'm just going to focus on the utilization of public primary care services during the COVID-19 pandemic. Okay, so early at the start of the COVID-19 pandemic, the World Health Organization has released an interim guideline on maintaining essential healthcare services during the pandemic. So if we talk about essential health services, it refers to services that cover individual, family, and also community healthcare. Usually includes outpatient, maternal, and also child health services, including immunization and also women's health services. So in this guideline, WHO recommends the monitoring of access to essential health services during the pandemic as one of the measures that is included in this monitoring is the utilization indicators. Okay. So here, I just want to emphasize that utilization is part of one of the dimension for access. And in this study, today's presentation, I'm going to focus on the utilization measurement. This is the main question that we want to answer during today's presentation. What is the impact of COVID-19 on the utilization of our public primary care services? Okay. So in this study is actually a longitudinal study that utilizes secondary data. We retrieve data from January 2019 until June 2021, where January to December 2019 is defined as a pre-pandemic period, and then January 2020 until June 2021 is defined as a pandemic period. The data was retrieved from the Family Health Development Division at the national level, and also for some of the indicators, we retrieved the data from the State Health Department, from the JKN. And this study includes all health and MCH clinics, which are all the KK and KKIs in our country. We measure utilization for 4 main services in the primary care, which are the outpatient, the maternal health, the women's health, and also the child health. For each of the services, there are about 2 or 3 indicators that covers utilization, that measures the utilization of the services. and also mainly on the attendances, but also other aspects such as the number of contraception or immunization given for each of the services. And these indicators here, there are about 11 indicators. They were selected based on the WHO document that was mentioned earlier, where there was a set of indicators that is recommended to be monitored during the pandemic. Okay, in terms of briefly on the data analysis, for today's presentation, I'm just going to share on the descriptive analysis only, where we perform, we calculate the differences in utilization between the pandemic and also pre-pandemic year, where we compare 2020 to 2019 and we compare 2021 to 2019. We look at the monthly percentage difference for each of the indicators, and we also perform the parity test to see the statistical significance. We also perform some advanced statistical analysis, but it's not going to be shared in today's presentation. Okay. I'm just going into the findings now, looking at the general overview, where I will share on the line chart for each of the indicators to see the general trend throughout the study period for all 11 indicators. Okay. So firstly here, we are going to the outpatient services first, where there are 3 indicators. The first indicator is OPD attendance. The second is on the radiology test performed, and also the third one is on the lab test performed. Okay, so this is a graph that I'm going to share for each of the indicator, where the x-axis is the time axis from January 2019 monthly until June 2021, and the y-axis will be the attendances in, for example, in OPD will be in 100,000. There are also the shades of the green represented the different waves of COVID-19, where the light green is the first wave, which is around January to February 2020. And the darker green, the second wave is between February until July 2020. And the darkest green, which is from September until June 2021, is actually on the third wave. As you can see, obviously here, for the OPD attendance, we can see that there's a steep decline in March until April 2020, which overlaps well with the implementation of the first MCO. And then, as we can see, starting from May, after May, there's the number then goes up, and then it maintained about the same level, but actually that new level is much lower than the pre-pandemic level. If the pre-pandemic level, we are looking at about 3 million or 3.5 million of attendances every month. After the first MCO, when the attendances recover a little bit, the new level is about 2.5 million attendances per month. So we are looking at the all KKs throughout the nation. If before it was about 3 to 3.5 million attendances per month, the new normal or the new level after the pandemic, after the MCO was actually about 2.5 million per month. Okay, so that's for OPD. Moving on to the next indicator, which is the laboratory test performed and also radiology test performed. I just want to highlight that these numbers actually exclude the COVID tests that was performed in KK or KKIAs. So this is the non-COVID services. Looking at the lab tests, yes, there's a steep decline also, just like the OPD just now during the second wave of COVID. But then the level actually recovers quite well, about the same level as the pre-pandemic after the MCO, or I would say after June 2020. Whereas for the radiology test performed, yes, there's a steep decline during the second wave, and then it recovers to a level just slightly lower than the pre-pandemic level. Okay, so that's the trend that we see in the OPD, in the outpatient services, OPD attendances, lab tests, and also radiology tests performed. Moving on to the next service, which is the maternal health, where we have 3 indicators. The first one is the number of antenatal care attendants. The second one is postnatal care visits, and the third one is 2 positive visits within 7 days of delivery. I'm just going to spend a little bit on this explanation, this indicator, the differences between the first postnatal care visit indicator and the second postnatal care visit indicator. The first one basically is just attendances of postnatal care mothers during after the first month of delivery to the clinics. Whereas the second indicator, it includes all other instances of contact with healthcare professionals, including home visits, or maybe when mothers come to the clinic for babies monitoring of NNJ. So those instances or those contexts are also included in the third indicator, which is 2 postnatal care visits within 7 days of delivery. Okay, so for maternal health, as we can see here, the first graph there is on the antenatal care attendance. Yes, there's a decline during the second wave of COVID, during between March, April, and May. But when it recovers actually quite well to the level that is similar to the pre-pandemic level. So as we can see there, where if the pre-pandemic level attendances is about 300,000 to 350,000, even after the decline actually recovers, starting from June 2020 onwards, the level is quite almost the same as the pre-pandemic level. And the second graph, which combines both the postnatal care attendances, where the blue one is the postnatal care visits to the clinics, and the orange one is the 2 visits within 7 days of delivery. So here actually we see quite a different pattern, not as similar as the OPD or the radiology or lab tests just now, where the decline or the reduction is not that obvious during the MCO. But in fact, I would see that we can see that the orange graph, which is the 2 visits within 7 days, which include also home visits, there's no much decline, which indicated that actually home visits, for example, is still occurring during the MCO period. Okay, so that's for the maternal health, and we're moving into the next service, which is the women's health, where we measure 2 indicators, which are the women's health attendances to clinic, and also the number of women receiving oral or injectable contraception. Okay, so this is the graph for women's health clinic and also for contraception. For the women's health clinic attendances, yes, there's a decline during the second wave, which is around April to May 2020. But the recovery after the MCO occurs a little bit slow, where, as we can see at the last steep increment in the attendances, and actually it just reached a new normal towards the end of 2020, about September, October. Whereas for the contraception, the decline is not that obvious during the second wave, but actually a bigger decline or a more obvious decline actually occurs during the third wave, which is about the end of 2020 or early 2021. So the contraception does not really reduce during the second wave, but actually it occurs more during the third wave towards the end of 2020 until early 2021. Okay, so that's for the women's health services. We are moving on to the child health. Where there are 3 indicators. The first one is the number of child health visits to the clinic. We also measure the utilization in terms of immunization given for 2 immunization, which are the DTaP and also MMR. Okay, so looking at here, the child health visit to clinics actually, as you can see, it mirrors almost the same as the OPD just now, outpatient services. Where there's a very steep decline during the second wave, about March until May 2020, and then it recovers. It increases a little bit, but to a lower level as compared to the pre-pandemic. So if you're looking at the pre-pandemic level, it's about 500,000 to 600,000 attendances per month. The new level after June 2020 is about 400 to 500,000 attendances per month. But if you look at the second graph, the one with 2 graph of immunization, which are the DTaP and also MMR, this pattern is actually very different as compared to other indicators, where there is not much obvious decline during the second wave or the third wave. The level is actually quite the same or quite stable throughout the study period between January 2019 until June 2020. So this is something which is very obvious that we need to highlight, and I'm going to say I will elaborate a little bit more towards the end of this presentation. Okay. Looking at this result, a little bit different. The same result, but then we show it in a different way, where this table actually show the percentage of change of all the indicators during pandemic year 2020 and 2021 as compared to 2019. So what we do here, for example, in January 2020, we minus with the January 2019 and we divide it by January 2019 utilization, and we get the percentage of change. There are different colors where the blue colors indicated that the change is more than 0%, which means there's a positive change. The 2020 or 2021 level is higher than 2019. And then we have the different shades of reduction, where the light orange indicated less than 10% reduction. The orange one between 10 to 20% reduction, and the darker orange between 20 to 30% of reduction, and the bright red will be more than 30% reduction. So at a glance here, we can see that there are some services which has more blue colors boxes as compared to other services that have more red or orange colors boxes. At a glance, we can see that the OPD, the outpatient services, has more reductions as compared to maybe we can say about the immunization or the postnatal care services where there are more blue colors here. Okay. Of course, we can see there are a few indicators that is much more affected. For example, the OPD attendances, radiology tests performed, and maybe the postnatal care visits and also child health visit. Okay. From here, I'm just going to focus on 3 of the main indicators for public primary care, which are the OPD attendances, antenatal care attendances, and also the child health visit. If we see the differences, the percentage difference of total OPD attendances, the monthly difference as compared to 2019, we can see that the OPD attendances experience between 15 to 39%, as much as 39%, starting from April 2020 until June 2021. And most of the differences actually is statistically significant. Okay, so throughout April 2020 until June 2021, OPD attendances experience very much reduction, and all this reduction is statistically significant if we compare with the 2019. Okay, so this is for 2019. This is for OPD attendances. And moving on to antenatal care attendances, although the graph looks similar, but then if you look at the magnitude, is very much different as compared to the OPD, where the biggest reduction seen in April 2020 is just about 13% for antenatal care attendances. And afterwards, the reduction is just merely about less than 10%. For the monthly attendances, and in fact there are some months where the utilization in 2020 or 2021 is higher than 2019. Okay, so that's for antenatal care. And moving on to another indicator, the main indicator, which is the child health indicator attendances. As you can see just now from the line chart for the OPD and also child health, the trend is quite similar. And as you can see here, if we quantify the differences or the reduction, yes, the child health reduced as much as 42% in April 2020. And afterwards, the reduction is still quite large reduction, which is around 20 to 15% of reduction. And most of the reduction is actually statistically significant. Okay, putting the 3 graphs together, as you can see here, the antenatal care attendances is much, I would say, perform better than the OPD or child health, with the reduction is much smaller in magnitude as compared to the OPD or the child health. Okay. This data, for the one that I shared on the line chart or this bar chart, it's actually at the national level. We also analyze the data based on the district level. Using this graph where we show the percentage difference for each of the district in this choropleth map, but we're not doing it monthly, we're doing it in a quarter. So for example, this map represented the monthly differences in mean attendance per capita for each of the district between January to March 2020. So the blue shades one are where the differences are actually positive. So there's an increase in the mean attendance per capita, whereas the orange or red colors are actually the reduction in the mean attendance per capita. Why we look at this here? Because actually, even though we see that the reduction at the national level, when we dive into the district level, they are actually the differences or the changes is not that homogeneous. There are some indicators where they're showing heterogeneous instead of homogeneous changes. Okay, this is just some reference for the different districts, the abbreviation and the name of the districts. So I'm going to show this choropleth map for 3 main indicators just now, which are the OPD, antenatal, and also child health. Okay, so here there are 6 maps in showing the quarterly differences in the mean attendance per capita from January to March 2020, and then until April to June 2021. So as we can see here, for the first quarter of 2020, as we can see, there's not much. Most of the districts are showing increase in the mean attendance per capita. But as soon as we move into April to June 2020, most of the districts are showing a reduction, where there are some districts showing more profound reduction as compared to others, as you can see in the different shades of red or orange colors. Moving on to July, September 2020, some of the districts has shown recovery, which means there's an increase in the level of utilization. And then as we go on to October, December, more districts, just a few districts showing increase in utilization. And January, March until April, June 2021, most of the district has not recovered well, except for a few districts that has shown recovery since as early as the mid of 2020. Okay, so this is for OPD. The next one will be similar map for the antenatal care changes. So if you can remember just now, yes, there are some reduction for the antenatal care indicators, but not that much as compared to OPD or child health. But then here, if we go into the district level changes, some districts are actually more affected as compared to others. Some districts are actually not affected at all throughout the pandemic. Here we can see there are a few reduction in Sabah, as you can see at the bright red colors, and there's a lighter orange colors throughout the Peninsular Malaysia, but many of the districts are showing the blue colors shade, which is actually the increase in the utilization. Okay, starting from July to September 2020, and then moving on to October, December, where there are more profound reduction in some of the districts, for example, in Sarawak, in Sabah, and also a few of the districts in the northern Peninsular Malaysia. But then starting from January to March 2021, until April to June 2021, more districts are showing the blue colors changes, where meaning there's an increase in the utilization. So I would say that in terms of the antenatal care attendances, the changes throughout the district is not as homogeneous as the OPD, where some districts are actually showing a different picture as the national level changes. Okay, that's for antenatal care. And then moving on to the last map, which is a child health at the district level. It's quite similar changes seen in the child health as the outpatient changes, but the recovery, I would say the district level recovery occurs as early as October to December 2020, where there are few, I would say quite a number of districts showing increase in the utilization as compared to 2019. And although starting from April to June 2021, it appears that more districts are showing reduction as compared to October and December. So this is maybe because of the third wave of COVID-19 in 2021, where we see the highest number of COVID-19 cases during that period. Okay, so that's the overall overview for the 3 main indicators. Now I'm just going to talk a little bit further on the immunization in the child health service. Just as an overview here, in terms of the child health, yes, we can see that the child health is actually experiencing quite a significant level of reduction. But if we look into the immunization, which is the DTaP and also MMR vaccination, the changes is not that much difference. Okay, this is child health reduction. But for the DTaP and also MMR, where the red colors is the MMR, the blue colors is DTaP, the reduction is actually not much throughout the study period, where even the highest reduction may be about 14% reduction. But most of the time, the changes is actually quite positive as compared to 2019. So putting the child health and also immunization graph together, the pattern that is seen in the child health attendances is not reflected in the immunization. So we can say that within the child health services itself, the immunization is quite preserved. So for the MMR and DTaP is quite preserved as compared to other services in the child health. So as we know that in child health, there are like weight and height monitoring, and then this infant immunization covers quite a big chunk of the services. But we can safely say here that the MMR and also DTaP is quite preserved as compared to other services in the child health. Okay, so that's the last slide for the findings. Just moving on to a few discussion and also conclusion. In terms of general overview of the different services, the OPD and child health services are more affected as compared to other services, for example, antenatal or women's health. Within the child health services itself, infant immunization are quite preserved, relatively preserved. And the reduction and recovery levels actually varies across the services, where there are some services which is quite stable, or I would say quite resilient as compared to other services, where even during the recovery, it doesn't really reach the pre-pandemic level. Comparing the changes or the reduction in utilization in Malaysia as compared to other countries here, the different bubbles or circle actually represent the degree of reduction, where the brighter red indicates a bigger reduction as compared to the blue colors. So as you can see here, actually a lot of countries reported reduce in utilization, reduction in utilization. For example, China for the OPD, Australia, Korea, Bangladesh, and etc. There are few services that is showing increase or not affected by the pandemic itself. For example, vaccination in Switzerland, or just a little bit of reduction, for example, vaccination in Turkey or OPD in Sweden. So I would say that what's happening in Malaysia is quite similar to what's happening in other countries, except for the vaccination, where there's just, if you go into the literature, there are very few countries that is showing preservation of immunization services throughout the pandemic. Okay, just a few of discussion points. One of the things that needs to be utilized is learning of best practices from the resilient services. This is an area where we can learn from each other within the primary care itself, but we have different services, and it appears that one service is more resilient than others. So what is the best practice that is implemented by the service that makes it more resilient than other services is one of the learning points that needs to be utilized in this study. And secondly, in terms of one question that arises from these findings from this study, what is the impact of reduced primary care utilization to our patients' outcome? As we know, primary care covers almost everything, like the outpatient, maternal health, child health, etc. Especially our NCD chronic patients, when we see that there is a reduction in the OPD utilization, what happens to them? Does their diabetes become worse? Does their hypertension become worse? Is there increased admission due to complications from the chronic diseases? These are the questions that need to be answered, but not within the scope of this study, but need to be further explored in other measurements. For example, hospital admission, mortality, and etc. So this question that arises from this study, of course, we need to further explore on other aspects of the patient's outcome. Okay. Just a little bit of strength and limitation of this study, and this will be my second last slide. The strength of this study, basically we utilizes the administrative data from the BPKK and also from JKN, which indicated that actually our administrative data is quite rich and valuable, where we can see where from this, just from the secondary data analysis, we can see that it can give quite a meaningful findings to show the changes in our public primary care during the pandemic. And in this study, we managed to cover more than 95% of all KK and KKIAs, where actually, depending on the different services, it covers more than 90% of the national utilization for the primary care. Some limitation, of course, the study does not cover the private sector primary care utilization, and we do know that some utilization of primary care occurs in the private, for example, the outpatient services, the MCH, which is not covered in this study. And of course, this study rely heavily on the quality of data that was received from the data source. Okay, so that's all my presentation. Thank you very much. If there's any, I would say just one references or one publication that I want to share here is our research highlight. You can scan the QR code to see the PDF file for the research highlight that gives a general overview of the changes in the utilization of public primary care services in Malaysia during the COVID-19. Yep, thank you very much. Go back to you, Cik Yana.
All right, thank you, Doctor, for your splendid and extensive explanation about your research findings just now. So I may now open the floor for Q&A session. For those who just joined us, don't forget to register yourself at the link provided in the description section. And should you have any question, drop your questions at the link provided, and I will read your question in this session. Okay, so we have the first question, Doctor. Okay. Yeah. This is from Muhammad Kadim AD. He asked, what is your advice, Doctor, for who has interest in quality management, whether research or audit, to be able to pursue his or her patient?
Okay, so that's quite an interesting question. One thing is, in terms of the quality healthcare in Malaysia, it is a career that is still not, I would say that in terms of the even postgraduate career is still not well established in Malaysia. So if we try to find master in quality healthcare within the local universities, it's not yet available. The opportunity, most of them actually available outside Malaysia. It is quite a challenging way, I would say it's quite a challenging pathway. But of course, you can dwell in, there are many job, I would say there are many on-training job that's available. For example, in PKD level, we have the unit quality. In the state level, we have also unit quality. And specifically in HSR, we have the Quality Healthcare Center. Yep. Okay, so that's your advice. Yes. All right. The second question, it's anonymous. Anonymous, okay. Yeah, anonymous. Yeah, okay. He asked, during the conduct of the study, what was the biggest challenges that you and your team had to face? Because your study was conducted during MCO time. Yes, so the biggest challenge, I would say, there are a lot of challenges, but I would say the biggest challenge is on the retrieval of data, where our data rely heavily on our data source, which are at the national level or the state level. There's a portion of this study which I did not present it here in this presentation today, basically on the timeliness, where we have to retrieve data from a system, from a database system at the national level, which actually took quite some time to be completed. Maybe because all this time the data is not utilized, it's not analyzed and everything. So in terms of the challenge mainly is on the retrieval of the data itself. So of course, we do need to do a lot of follow-ups to our representative from each of the sections. And also, because of the data is not real time, so we do need to rely on the available database that is before we can proceed with our analysis, etc. Okay. When you said one of your limitations to the study is due to the quality of the data, what do you mean? Can you elaborate? Yes. In terms of the quality of the data, even though I put it as limitation, but one thing that I want to highlight that the data that we use is the one that is used for national level publication. For example, in terms of, we have publication from the BIK on the attendances of clinics, attendance of antenatal care services. This is the source of data that is used for those kind of publication. It's just that there's a like 1 year backlog before the national data release officially, and also just as I mentioned just now, our study intend to cover the whole KK and KKIs. But when we do the cleaning and etc., we only managed to cover about 95%. So because of the manual way of retrieving data, of asking for data from the state or from the BPKK, there are some of the facilities that is missed out during the data reporting. So we can't guarantee 100% of data from all the KK, but at least we can manage to cover about 95% to 98% of the facilities. Okay, so next questions. Why did you expand the study to private facilities? That's a very challenging. Okay, that's question. It is a interesting question, but to perform the data at the private sector is going to be very challenging. Of course, it needs another level of bureaucracy and everything, which may take more than a few years to be completed, and of course, in terms of the data reporting system or the availability of data is not as it's not similar to what's happening in MOH, what we have in MOH. So, in terms of the data might not be similar. The way in terms of the measurement could be different. So of course, if you want to expand to private sector, it's going to be much more. We have to go into the details of utility before we can proceed with the private sectors.
Okay, that's a challenge.
Yes.
Okay, next one. Did you explore what is the most common reasons for patients not going to our healthcare facilities during the MCO period?
Okay. There's another part of the study where we distributed a questionnaire which explore on what are the barriers to healthcare accessibility during COVID-19 pandemic. Yes, we do have that portion of this study, which I did not present the findings here. And the main barrier is patients or our populations, our people are afraid to go out due to COVID-19, which that barrier does not exist during other period before the pandemic. But because of the pandemic, the main reason that impede or that puts barrier to the healthcare utilization for people going to the clinics and going to the clinic for their follow-up or for tests or for radiology tests and etc. is because of they're afraid to go to the clinic because of COVID-19.
Yes, if I were in their shoes, I would say that if I'm the public,
yes,
what's the reason I go there? That
yes.
is the center of transmission. This is transmission.
That's very interesting actually, because as we can see, for example, for the immunization just now, when I say that the utilization is not much affected, what makes the parents, for example, mothers, still going for their baby's immunization as compared to maybe antenatal care or maybe OPD services? So that's an area which is not yet explored in our study. But of course, it raises an interesting question. What makes the parents see that the infant immunization is very important, that they will go even during the pandemic, even during the MCO, as compared to going to appointments in the for the OPD, for example, chronic diseases and etc. So, of course, that's an interesting area to be explored in the future.
Okay, nice. All right, that's the last one, I think.
Okay.
Yeah, the last one. For patients who has been rescheduled or channeled to other non-COVID hospitals or clinics, did they ever complain about their increasing out-of-pocket expenditure because they kena travel jauh kan?
Okay.
Adakah you explore dalam you punya study? Yes, that's the question.
That area is not explored in our study, but of course, I think there's a little bit in our survey for barriers for healthcare utilization during the pandemic. Yes, there's a little bit of some portion of the respondent who say that increase in financial burden, for example, for travel or for distance, for example, in terms of expenditure to cover for PPE and etc. For the mask, we have to wear masks during the MCO and everything. There's a portion of our respondents who say that is a barrier for their healthcare utilization or accessing the healthcare. But in terms of the out-of-pocket expenditure and everything, we did not cover in the study.
You didn't explore about that one. Okay. I think this is really the last one. Do you have any future research related to this?
Future research? No, there's no future research, but we do have another study that explore. This is a collaboration with the ICR, which covers the hospital site utilization, where we look at the inpatient admission. For example, inpatient admission, just to see if the reduction in the public primary care, does it reflected in the hospital? For example, is there an increase in the admission? Is there increase to emergency department visits and etc.? We do have another study that covers that.
Okay, so what's your take-home message for today?
Take-home message, interestingly, of course, as I mentioned in the discussion just now, patients' outcome as a result of this reduction in public primary care is, of course, something that we need to see. And of course, there's so much thing that we can learn during the COVID-19, how we adapt, how we tailor our services. In the midst of facing the challenges that is posed by the COVID-19, how do we still maintain the services to other essential services, to the non-COVID services. And of course, this is of course a very challenging task to be conducted during any crisis, any health crisis. But as you can see here, that we do show some resilience, and we do show some kind of our health system do show some resilience during the COVID-19, I would say. Yep.
All right, so that's wrap everything up for today. For those who join us, thank you for joining us, and don't forget to subscribe to our YouTube channel. So see you when I see you. Till we meet again, catch you later. Bye.